Okay, good morning. Okay. Yes, a few words to welcome. We are very few of us, but welcome everybody to this first webinar of EASOM in 2021. We are today very happy because we have Professor Raymond AGIUS as guest speaker. He has been very active and appreciated member of EASOM for many years, and now as emeritus professor, he's been extraordinarily prolific at developing exceptional work that contributes to highlighting the important role of occupational medicine in COVID-19 times. Thank you, dear Raymond, for that and for being here with your EASOM colleague. Thanks a lot.
Thank you, Begonia. Thank you, Peter. It's a privilege and an honor to be invited to talk to you. And today my talk will be in two parts. The first part will be about occupational attribution and the second part about worker protection. Both of these are huge topics, so I'm not proposing to cover everything, but to pick out what I consider some important points. The next slide is merely a statement of my current interests and basically to confirm to members of the audience that I have no interest in selling respiratory protective equipment. The objectives, therefore, as I've just said, are twofold. First, to look at the different approaches in the attribution of COVID-19, and I shall go over this in four different headings: by job, by exposure, by specific workplace, and by specific patient. And then I shall address occupational transmission, but that's a huge subject. So I shall focus mainly on airborne transmission by aerosol, mainly on respiratory protective equipment. That's not to say that other issues like ventilation and so on aren't hugely important, perhaps more so, but I will restrict myself to where I am best able to contribute to this meeting. Right, attribution of COVID-19 to occupation. As all of you know, there's a lot of emphasis now and attempts to label COVID as an occupational disease. It's a simple question, but with a very, very complicated answer. Why do we want to attribute COVID to occupation? Well, we might want this to be able to count numbers of cases, to measure the burden. For example, if we're comparing between countries, within industries in the same country, or looking at trends to see whether there has been a reduction in the occupational burden of COVID. Of course, you don't need to call it an occupational disease for epidemiologic purposes. You can measure things like population attributable fraction, for example. However, if you want a week-by-week count of cases, then you need to have some form of a simple, not necessarily accurate, but it has to be a consistent definition for comparison purposes. Another reason why you might want to attribute this label is to be able to identify what instances need further investigation. Again, in that case, the definition could be wide-ranging. You don't want to miss cases. But if so, you might then have to have some form of prioritization of the investigations which follow so as to learn and teach lessons to protect workers. Or else maybe you want to attribute COVID to occupation for the purpose of compensation. If you want to do that, do you want a system which will give you a very simple automatic entitlement to compensation? If you had this diagnosis and you worked in that job, you get compensation? Or do you want something which will be in some respects more refined? It can deal with more specific individual circumstances, strange jobs, extraordinary exposure, and so on, in which case you then need some form of enabling mechanism and then specific evidence to be produced for individuals. But that's very time consuming and can lead to inconsistencies. So maybe you need a model which has a combination of both. So how can we approach this dilemma, this challenge? I'm going to look at this under four headings, which I mentioned earlier, and which I shall now take in turn. Let's take specific occupations. If you have good epidemiological data, and now we have a lot about COVID, where you can reliably define the disease or the condition. If you're talking about a degree of disability, for example, not just the disease. You have good data on exposure response. If those studies take account of confounding and other biases, if they're consistent and corroborated, if you have a high enough threshold of evidence, many authorities, not all, will take a doubling of relative risk as being more than likely on the balance of responsibility. Oh, so balances, sorry, there was some noise in the background which has distracted me. Doubling of relative risk. I apologize. And of course, you may have some other corroborating information. You can then get compensation by job class. For example, this is a study based in the UK, published after the first wave, a cohort of 120,000 people, so it's quite huge, with serious disease being defined as having a positive RNA test in a hospital context, with good attempts to take account of confounders. And we can see there very high relative risks of about 8 times for healthcare staff, not just the clinical staff, but even supporting staff, porters, and so on. However, it also showed increased risks in other workers, for example, more than doubling of risks in transport workers. If you have this sort of consistent high-quality study, then you could define COVID as being attributable to occupation on the basis of more than a doubling of risk in those diseases. These are some routine data, again, British data, from the Office of National Statistics, looking at the age-standardized mortality rates involving COVID. And this column here shows the relative risk. And here I've selected those which have, in men, more than a doubling of risk in that data set, and with more than 20 deaths. And as you can see, a wide range of occupations. Those in red are occupations involved in looking after people who are known or highly likely to be sick with COVID. But note a very high number of occupations which do not deal with known sick people, things like chefs and other people in the hospitality industry, drivers, and so on. These all show a very high risk because of exposure to people. I've now looked in more detail at a subset of those data, here comparing different categories of drivers. So we have the relative risk there, and the vertical line corresponds to the comparator population, namely all people of working age of the same gender. And as you can see, in some categories of drivers, taxi and bus drivers in particular, the relative risk is very high, whereas in van drivers or heavy goods vehicle drivers, the risk is really not different or not very different from that of the population in general. Of course, what do the first two categories have in common? Taxi drivers and bus drivers are exposed to people. Van drivers, I suppose, see you when they drop your package at the door, and heavy goods vehicle drivers don't. So the association with being exposed to other people, even though they are not known to be sick, is quite high. So those sort of data provide a basis for categorizing occupations on the basis of the relative risk of COVID and acting accordingly. Now, in other diseases, if we're dealing with silica, if we're dealing with noise, if we're dealing with radiation, we can measure those things and measure exposure and attribute a likelihood that some disease arose to the fact that the exposure for that individual was high. Unfortunately, with COVID, it's almost impossible to measure exposure directly. It's a very fragile virus, as you know. However, it may be possible to have job exposure matrices, other means, other models to permit us to have a pragmatic means of indirectly estimating exposure. These are some such data. These are based on a US method, which people have tried using in the UK, in which you look at occupations by the physical proximity to others, that's the horizontal axis. You look at how frequent the exposure is, that's on the vertical axis, and you can then begin to plot a wide range of occupations in that way. And this has some utility for an epidemiological purpose. Whether it has utility for compensation purposes, I don't know. What about individual workplaces and clusters? There have been thousands and thousands of such clusters reported. This was a report published in August of last year from the European Union and some adjacent smaller states. You can read it. Yeah, yes, they warrant investigation. Yes, they can be used to associate occupation to exposure, associate disease to occupational exposure, But they have many shortcomings. We need a generalizable, consistent definition. Many people have used the definition of 2 confirmed new cases over 14 days, but if you look at different countries, the definitions aren't the same. And what if those cases were not necessarily contracted at work? What if they happen to be 2 people who are neighbors and who go to work in the same car? Does that make it a workplace cluster? So you need a consistency of definition. You need a consistency of methodology. You need an investigation which looks at relationships within the cluster in time and in space. You need backward tracing. Genomic analysis would be ideal because in some instances it can be almost conclusive proof. In many instances it doesn't help. How do you assess exposure? How do you take non-occupational exposure into account? It's all quite a difficult issue. And ideally, we need an agreed minimum data set that all the countries or organizations participating in this collect this minimum data set so that then when the findings are analyzed and shared and lessons learned and disseminated, you have something that is valid and that is generalizable and which provides the basis for comparisons. What about looking at the issue in individual patients? You can do it. Many countries, for example, have quite generic provisions for occupational accidents, and you could consider an exposure to an infectious agent as an accident, and you could treat it as such. And you can have physicians addressing this as individuals, you can have panels, you can have enforcement bodies, you can have courts, if you like. Diagnosis is quite simple nowadays, but it's not always simple historically. At the start of the pandemic, many people had classical features of the disease, but missed tests because they weren't so widely available. Antibodies, as you all know, have their difficulties in interpretation, especially now that people are being vaccinated. You would need very strong criteria, or at least good evidence-based guidance on how you associate the relationships of time and space with exposure. How would you determine that an exposure threshold was high enough? Do you assume it in various occupations, like the data that we've discussed before? Or do you go more specifically than an occupational category and look at specific tasks and what people did? And how do you take the competing non-occupational exposures into account? And these difficulties remain, and they need to be resolved, especially for the purposes of equity and fairness, if people were to be using these approaches for compensation, and also if one were to use these data for comparative purposes. In the UK, data are collected on an individual basis by virtue of a law which obliges employers to report. These show the data from for most of the pandemic, with a huge peak of more than 1,000 cases per week in the first wave and an even bigger peak in the second wave. But there are many, many flaws with this sort of data. We do not have the time to go into these in detail. I've published at least 3 papers on the subject, but just to give you some example of the shortcomings, it relies on the judgment by the employer, and many employers are reluctant to report. Some occupations can be restricted in the sense that the enforcing authority says, we only want to hear as a rule from people who are exposed to patients and sick people, so they're trying to discourage reports from, say, bus drivers and taxi drivers. And thirdly, they also say you've got to take protection into account, which is, on the face of it, a fair statement. But if you dig deeper, you see that it can lead to huge biases and misleading conclusions. If you say that a nurse is adequately protected if he wears a surgical mask, and then if he contracts COVID, you say, well, no, it wasn't through work because he wore a surgical mask, and you don't report the case, then you are in fact not investigating the very sort of case which I believe warrants strong investigation, because I believe that that degree of protection is not and was not good enough. So these data are quite flawed in many ways, but they're better than nothing. Okay, that now takes me quite conveniently into the second part of the talk, which is the prevention of occupational COVID. It is still hugely important, not just to investigate what went wrong, but because we are still faced with a huge threat. We are faced with threats from variants, and we do not know to what extent we can succeed to protect people from vaccination, either in terms of the logistics of the exercise or in terms of how. Sorry, I've got background noise from one of the delegates. Could I please ask the delegates to mute? The vaccines we have may work now, but they might be functionless in a year's time. We do not know. Obviously, our interest in this body is to prevent exposure at work in the whole of this pyramid. That's what we are here for. We've got to bear in mind, as I said earlier, that exposures arise not just from sick people, but from contact with other workers, for example, in food manufacture and call centers, and in close and frequent contact with general public. And the epidemiology has shown all these three to be important. I'm not going to go into detail in all of these. Indeed, I'm sure that all of you know about the risk assessment steps and the ways of controlling, starting from controlling the source, eliminating the source, testing people, isolation, and so on, pathway controls, ventilation, filtration barriers, and work practices. And therefore, I will focus mainly on receptor controls, protecting the individual, and mainly on PPE. Now, historically, these are the transmission pathways which people considered. They've been very disappointed personally that not enough attention has been devoted by the World Health Organization and others to the last pathway. We know historically from guidance such as this one published after the previous SARS coronavirus outbreak, we've had them in the past, and we've had MERS in the past and so on, and that did suggest that aerosol transmission was important and that you needed respirators to protect staff, even in the routine care of patients, nurses, porters, all these people. And indeed, at the start of the pandemic, the European Centre for Disease Control issued what I thought was good advice, that the minimum composition of a set of PPE should include a respirator, a filtering face piece respirator. But the route of transmission was underestimated by the World Health Organization and others, in my opinion, and too late and too little, too few steps were taken to control it. The precautionary principle should have applied. There is a lot of evidence suggesting airborne transmission. We know that the risk indoors is much greater than outdoors. We know that it's especially poor, there's poor ventilation, even with no contact, and there are lots of documented instances in hotels, in choirs, in churches, and so on. We know about super spreader events where people have not been close enough to touch or to expose each other to ballistic droplets. That means those droplets which actually can be spat out of the mouth and which fall. There have been some data where aerosols recovered some distance from patients. We know of other diseases like tuberculosis, measles, and chickenpox, which are almost impossible to culture in the air, yet we accept our airborne transmitted, and there are lots of laboratory studies. I can share the one link with you later. And it seems to me that there's been a higher standard of proof that was expected for airborne transmission than for the historically accepted routes of contacts, fomites, and droplets. And what this meant, especially in healthcare, is that people designated things like aerosol generating procedures largely by consensus. They said, oh, well, you only need respirator protection if you're intubating or ventilating patients. However, there is no evidence that coughing or talking to patients generates less aerosol than these so-called aerosol generating procedures. In fact, quite the opposite. You generate more aerosol from coughing and talking, and no evidence that health workers caring for COVID patients without engaging in these procedures are at any less risk. Again, the evidence suggests the opposite. For example, I've just got a couple of examples of evidence here because time is limited. These are data showing comparisons of aerosols being generated. These are not aerosols measuring COVID. It's very difficult to measure the SARS-CoV-2 virus, but they do go over a huge range of aerosol sizes, as you can see by the colors. And the panel on the left of this deals with normal respiratory activities like coughing or doing a forced expiratory maneuver or shouting. And the panel on the right here looks at respiratory therapies like positive pressure ventilation set at their maximal settings. And you see that the physiologic activities generate more aerosol over the whole size range of however you define them than these activities. Yet the staff exposed to the exposures on the right were told you must wear respiratory protective equipment, proper equipment, respirators, and those on the left were told you can get on with surgical masks. Not everywhere, but in many places that's what they were told. And that's not good enough. Here we see another study, again conducted in the UK on 160,000 healthcare workers, again based on the data from the first wave. They did lots of comparisons showing the relative risk between healthcare workers, members of the household, and so on. I apologize for the spelling mistake, which I'll correct later. But they also did comparisons of the front door healthcare workers, those first in contact with sick people in accident and emergency departments, in the medical ward and so on, with those staff in intensive care units. And they found that if you were a front door worker, you actually had twice the relative risk than if you were working in an intensive therapy unit. So these front door workers, the general medical wards and so on, have not been adequately protected. Indeed, I and others suggested in the BMJ that this concept of aerosol generating procedures was really an attempt to rationalize the rationing of protective measures. Namely, not enough was done to have these protective measures ready in time, and therefore not enough workers were protected. And this very crude system based on aerosol generating procedures was just the means to cover, in my opinion, I'm sorry to have to say this, but it is my strongly held opinion, to restrict the availability of protection. And what is really sad is that by the time the second wave came along, the stocks of protective equipment had been hugely built up. A lot had been learned about ventilation too. And in the summer of last year, a lot more could have been done to improve ventilation in our schools, in our hospitals, and a lot more needs to be done to reduce the risk in the future. So we see now that the NIOSH in the United States very strongly advises respirators for most healthcare personnel caring for confirmed or suspected cases. Regrettably, the WHO, even as recently as February, was still recommending surgical masks. They did in December say, if it is feasible and if it is possible and if cost isn't a problem, give respirators to other staff. But I think that the advice should have been stronger than that. And even now, as recently as 8 days ago, the World Health Organization is still not coming out clearly and explicitly conceding the aerosol and airborne transmission is slowly and begrudgingly being dragged to accept this. But this acceptance is important. It's important so that people take the proper steps for ventilation of any premises where people might be exposed, and for giving people personal protection of a high enough standard where such ventilation is not yet feasible. This is effectively my last substantive slide before the conclusions, because I want to allow debate, time for debate. And it is about vaccination. Many people think, oh, well, it's just a matter of time. We'll vaccinate everybody and we will be all right. I think we should be careful in letting people run away with that conclusion. I think we need continuing efforts, especially for frontline workers. There is a continuing community infection and likelihood of importation of new variants. Of course, some of those workers will not have a good enough response to vaccine. They will not be adequately protected. And we know that these new variants will then even increase further the risk in those people, because the variants have an increased transmissibility and may have, and we already know some of them are less susceptible to current vaccines. And we need to be ready to give repeat vaccination to frontline workers for the new variants as they come along. Right, I shall now come to my conclusion slides, and then we can have a debate. A single definition of occupational COVID or COVID caused by work might not be feasible. Indeed, as I said, it might not even be desirable, because it depends on the purpose of such a definition, whether you're doing it for counting cases to measure the burden, whether you for observational epidemiology to compare rates for surveillance, whether you're doing it for investigation of workplaces or clusters, or whether you're doing it for individual compensation. The definitions and the criteria might be different. And of course, there is always this background debate of how do you take non-occupational exposure into account. Sometimes you can exclude it, like with genomic tests, but often you can't. And in relation to the second part of my talk, the pandemic protection of workers, I haven't had much time to go into history, but I did show you at least one historical slide. We did learn, by we, I mean the scientific community, from previous outbreaks, what the nature of SARS coronavirus is, the whole family of them is, and it can be airborne, and you need good protection by way of ventilation and personal protective equipment. Yet when the pandemic struck, many authorities said, we know nothing about this. This is unprecedented, and they therefore did not take enough precautions. We also had, in my opinion, a lot of public health guidance, which as a consequence of that was weak, because it didn't recognize aerosol spread. And many people just simply thought that it could extrapolate public health guidance to workplaces, ignoring the special responsibilities owed to workers and the higher exposures associated with occupation. As I've said repeatedly, but I make no apologies for repeating it, probably the greatest deficiency is the airborne transmission of viral aerosols. I shall stop there to allow plenty of time for discussion, because I know that one of the values of these sorts of meetings is not just to listen to people like myself speak, but for the members of the audience to bring their own comments, their own wisdom, their own experience, their own challenges to the situation. Thank you very much for having invited me.
Thank you very much, Raymond, and for excellent presentation. And I would like to mention that we had also one very nice presentation from the Lode Goderis, and he presented almost similar results on the healthcare workers' relative risk for COVID-19 in the first wave. But he also presented the results of the second wave in Belgium, which was below 1, which was very interesting for us. And then he showed us also data that in the second wave, the most affected, the people with highest relative risk were waiters, bartenders, and similar group of workers, which is rather interesting comparing to expectation of lay public.
I showed that earlier in the in today's meeting in one of the early slides, the high risk in the hospitality sector. And of course, those are young people, many of whom have not yet been vaccinated, and who all of a sudden are now trying to welcome people in. They are at high risk.
Okay. I invite colleagues to ask Raymond questions about his presentation. Okay, Stefan, please.
Yeah. Hi, can you hear me?
Yes.
Yes.
It was a pleasure to listen to you, Raymond, as always. And I just wanted to make a comment, or maybe just share our experience with Italian healthcare workers when we analyzed the exposure and more how they got infected in the first wave in Italy in February, March, and April. Our conclusion was that the workers not working directly with COVID-19 patients in wards where you have aerosol generating procedures just didn't follow all the recommended precautions that were expected from them, because their logic at the moment was, okay, I'm not directly involved with COVID-19 workers, so with COVID-19 patients, so maybe I don't need to wear a mask. And my question or comment was that it's really difficult to attribute someone getting infected to the failure of personal protective equipment, or to the failure of following the precautions that were recommended. I mean, at least in Italy, maybe even less, in Serbia a lot, you see healthcare workers which wear masks just under their nose or on their forehead or below their beard or something like that. So it is difficult to isolate and to look at what would happen in a perfect scenario where then aerosol exposure would become really a relevant source of exposure. And I've been trying also for some other reasons to find the literature confirming or not confirming aerosol exposure, and if the virus is airborne, or all these titles that you can find in journals, and mostly they are commentaries. So you don't find any research articles. And for me, the question is it so difficult to prove that it's possible to get infected just through aerosol exposure? I mean, I imagine it would be relatively easy to put something that would collect aerosol somewhere far away from droplet exposure, and this way you would prove that this virus is viable. So why is it so difficult to prove or to disprove that there is aerosol exposure?
Look, I'm not a virologist, so I'm not speaking with authority on what I'm about to say now, but I have spoken to people who are doing exactly that sort of research that you described, like John Cherry in Scotland and so on. Unfortunately, the best sampling device for SARS-CoV-2 is the intact human being with ACE receptors. The moment you try to start collecting this virus on filters or something like that, it's not like a quartz particle. It dies, the RNA breaks up, then you say, we have found an RNA signature, and other people turn around and say, but an RNA profile is not a viable virus. It is a very fragile virus. This is not a bacterium with a capsid that you can capture on a filter and then grow. It's actually very, very fragile. So that's why those studies that you suggested are not so easy to conduct. But people have conducted studies in animals, in ferrets, at a distance from each other, and with a channeling of air in such a way that it's most unlikely to be permitting droplets to go through. It must be letting through aerosol go through. And those animals catch the disease. And then there are studies in humans where people have luckily had videos of restaurants or whatever. They can see where people were sat. They can see who went to the lavatory and who didn't. They can see who touched which door and who didn't. And they can tell that those people in those restaurants, hotels, and so on have caught the disease, and they can find no other way of plausibly explaining it except that they breathed the same air at some distance from somebody who had it. And I believe we should work on the precautionary principle, and there is a strong enough evidence for aerosol spread. That's my view.
Oh, thank you for your answer. The problem that, again, I would like to underline also with our work was that even though, for example, we tried to prove that health workers got infected from one another, the question was, how can you be sure? And without very advanced techniques of proving that the same RNA is found in two colleagues that work together, it's really difficult to prove that this was not a mixture of occupational exposure and community exposure.
Oh yes, you're absolutely right. And in fact, I had a previous version of this presentation which had a slide of some of your work. But because I had to cut down on length, I just kept the British slides. But yeah, you've done some very valuable stuff, Stefan, you and Claudio, and so on.
Thank you.
Okay, thank you, Raymond. Is there any more questions for Raymond? Some proposals, discussion?
Raymond, could I ask a question? Is it okay to go ahead?
Yes, yes, please.
Yes, sir. Thank you for the presentation. Very, very interesting. Just one of the issues that came up in Ireland, you know, with the Biological Agents Directive of 2000 and the categorization as a hazard group 3 biopathogen. And I suppose it relates to whether, you know, employers, you know, the excuse was that we're adhering to national public health or WHO guidance, which obviously on the ground wasn't controlling the risk. And I'm just asking the question, is there any moves to, say, prosecute under Section 36 or 37 of the Health and Safety at Work Act in the UK, or Section 80 of the legislation in Ireland, for the employer's failure to provide the whole integrated hierarchy of control measures? Because the emphasis was on the public health IPC paradigm that, you know, related to fomites and droplets, and there was resistance to engaging with the health and safety, you know, controls that would be appropriate for workers, you know, occupationally exposed.
Are you asking me, Peter?
Well, yes, because
okay, well,
it's about a systems approach to whether the employer deployed the proper systems.
Yes. Well, as you know, I don't work and never have worked for the Health and Safety Executive in the UK, so I cannot give you an official answer. I can give you my impression from the outside, and I have written to them. I've sent about 3 or 4 freedom of information requests to them, some of which they've answered and some of which they have refused to. I think the people in the Health Safety Executive, the actual scientists and public servants in the UK, are trying to do a good job, I think. But the politicians, I do not think, are letting them. I'm sorry to have to say that. Our Minister for Health in April of last year, and I wrote about this, I published about it, actually discouraged and misled people when he spoke in Parliament, discouraged cases from being reported to the Health and Safety Executive. The Health and Safety Executive did not publicize the legal means for the cases to be reported. Out of 20,000 cases that were reported, they issued only 1 improvement notice from the set that I had. And out of those 20,000, they only did 500 investigations. So some of them, obviously, investigations might have dealt with more than 1 case, and they wouldn't give me the data the way I wanted it. But it's only a very tiny fraction of cases which have been investigated. And when I looked at the database for the enforcement and audited 100 of the enforcements that they did, most of the The only prohibitions were when they found something not related to COVID, like asbestos or an electrical hazard. And the only enforcement they did in relation to COVID were quite primitive things, people not having a wash hand basin, not cleaning the floor. I mean, that's sort of Factories Act standards of 50 years ago. And I found only one instance in which an enforcement notice was issued to an ambulance authority for not having trained staff adequately in personal protective equipment use. So to me, all that suggests that there has not been, not just not enough reporting, as I said earlier, but not enough investigation and not enough enforcement. That is the picture that I get from the information that I have been given. As I said, I haven't been given all the information I've asked for.
Thank you. I'd just be interested whether any others, you know, in other European countries have experience of how their regulators have approached it.
Okay.
Peter, may I refer this question to Peter?
Yes, 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 of course.
I know for Serbia even better than, much better than me. So the question, if I understood correctly, was there any, how to say, regulation used against not adequately protecting workers, not only health workers, but other kinds of workers? And I can say from another research we did in Serbia, which has been, I cannot find it now, but I can send it to you, that almost 50% of workers, it was a survey, stated that they were not adequately trained in using PPE, for example, or they don't feel they were given adequate equipment for. So this is, of course, it's a survey, so it's an opinion, but it's not 1 or 2%. It's a much higher percentage of workers. So were there any opportunities in Serbia for the asking for more?
Okay, thank you, Stefan. Somebody else? Spain? Begonia, we do not hear you.
I think that there is no such a survey,
Okay.
but I think the situation, it is quite similar. Yes.
Okay. And in Luxembourg?
Can I come in?
Yes, please.
Yes, I'm from Hungary, and in Hungary the investigations weren't done on site. It was shifted to only to questionnaires sent out to the employers, so there could be no real sanctions or other enforcement done. But our experience is that the employers themselves, the hospitals, realize that there are shortcomings, and they were acting there. For example, many cases were due to workers having coffee or lunch at the same place, so they got infected from each other and not from directly the patient.
I think Ferenc makes a very valid point. I think some employers said, oh, well, these are the guidelines we've got. We just follow the guidelines and that's it. But other employers did a much more thorough risk assessment. They said, let's look at the evidence. Let us look in detail at where our people have the recreation as well as where they work, the specific circumstances in their own hospital. And many of them then provided protection which was over and above what the official guidance was, because they wanted to take appropriate precautionary steps. And those hospitals and their staff performed better.
May I share my screen for a second? I found the result I wanted to share with you. Do you agree, Peter?
Yes, yes.
Okay, I'll unshare mine, do I?
Can you see this? What
Yes.
I'm showing? So this is the survey that we did. It was done on. This is almost 1,000. It was 1,500 in total, but 992 were engaged with SARS-CoV-2 positive patients. And here are the questions that I was referring to. So, were you trained to use personal protective equipment? Only 45% said yes. Was their equipment available daily? Only 66% said yes. And if they used as recommended, yes, they used, but obviously when it was available. So this is, and I don't see there was any room for complaining at that time.
Okay, thank you, Stefan. Some other experiences from Europe.
Did the
Somebody tried to connect.
I just wanted to
Yes.
follow up and whether the classification of the COVID-19 as a hazard group 3 biopathogen, apparently on the 14th of May 2020, had that any bearing in the context of the directive 2050/54/EC in how the relevant jurisdictions handle the approach to the pandemic? I suppose our own experience is that our health service executive, which is the equivalent of the National Health Service, only brought in its policy on the 7th of September, having ratified it with the unions on the 15th, and they didn't proceed to revise the respirator guidance until the 15th of January 2021, surge over the Christmas period into early 2021.
Okay. Some other European experiences, maybe Luxembourg. Nicole?
Okay, I have no data about it. So there were minimal guidance for each kind of occupations that had been done by the government, and it was controlled by the labor inspectors. But I have no data about how it was followed. Was it very good followed or not? So I have no really data about the results.
Okay. Maybe from Latvia, Maya Eglute. Maya, please unmute yourself.
I think Maya.
Maya, please unmute yourself. We do not hear you, Maya. We do not hear you, Maya. I'm really sorry that we could not hear Latvian experience. So, is there anybody else who would like to ask something, Raymond or some of us?
Peter, I want to say something only to respond to Peter.
Okay. Yes.
I think the experience in Spain, it is similar that has been commented on other countries. We got guidelines and employer guidelines, but maybe they were not so adapted to the evidence we got now. So there is a big gap. We also have this effect of the European directive and the recognition in group number 3, and it has generated some consequences. Also on the side of the recognition of occupational disease of COVID-19 in health workers, but only when it is very clear that they have been exposure, they had exposure. So I think there is much to do. It would be very nice that this kind of survey that the colleague from Belgrade are showing us could be extended to other countries. It would be very nice to compare. And I think we did, for example, this is very clear for the recognition of occupational disease of COVID-19 in health workers or other workers. There have been differences among countries, even your countries, there are quite a lot of differences, but in general, there is some consequences for this directive, and we should try to cooperate in research and to have the whole landscape and evaluate what we have done in many perspectives. I don't want to talk too much. I think we are running out of time. I want to thank Raymond. I didn't ask any other questions because I have the privilege of having here at the university giving a master conference. The students were very, very happy. The feedback were the best. I'm very impressed because his language, his use of Spanish, that was really brilliant. So I only can say goodbye and give everybody thanks for being here. Congratulate Peter for this also, and expect we can cooperate in this way many other times in future.
Thank you very much.
Thank you.
Thank you, Raymond. Thank you, all of you. And according to today's discussion, I believe that we could continue with such COVINARs in the near future. So, Raymond, you want to add something, please?
No, I just want to say thank you very much, and I have to leave for another thing which starts in 4 minutes. Thank you, everybody, and goodbye.
Thank you to all of you, and hoping to meet you soon on the new EASOM COVINAR. All the best to you. Stay safe.
Thank you. Bye.
Bye.
Bye, everyone. Have a nice day.
Goodbye.
Bye.